Great. Well, it's my pleasure to introduce Dr. Vera Fridman. Brian Callahan here. I think everybody knows me, but my job is to introduce Vera, who I had the pleasure to do residency with at the University of Pennsylvania. Vera is now an associate professor at the University of Colorado. She got there by way of starting with med school at Tufts, and then residency was at Penn. She did a neuromuscular fellowship, both at the Brigham at Harvard, as well as ended up doing more training at Queen Square. So had a really great training background. Started off as her faculty career at Harvard before transitioning to Colorado. Things that I found very impressive when looking at Vera's resume were that she won 2 teaching awards as a resident, including one named after one of my main mentors at Penn. So that's a pretty awesome achievement. She also is internationally recognized, has a lot of involvement with the Peripheral Nerve Society, which is an international society, one of my favorite meetings and groups. And she's done, maybe 10 things for that, including now she's on one of the boards with me, but she also was integrally involved in the junior committee. And right now, Vera is on a K-23 award, so she's kind of made that successful transition. I'm looking forward to seeing her career blossom as she, starts getting R01s and things like that. And her career path's been very interesting, where she started out looking at hereditary sensory autonomic neuropathy, and even did a clinical trial on that. And some things that she noticed with that condition had parallels to diabetic neuropathy. And she's kind of switched into looking at atypical sphingolipids in diabetic neuropathy. And so just very cool work, grounded in good science. And I really look forward to her talk, which is going to be from rare to common neuropathies, measuring change over time. And with that, Vera, take it away.
Thank you so much, Brian, for this introduction. And it's really a privilege and an honor to be here. There are many people at this institution that I really think so highly of, and it's great to be joining you. So I have no conflicts of interest for this talk. And this talk is going to sort of tell 2 stories that I hope are going to fold together and echo each other for all of you. So the first thing we'll do is we'll talk about some of the biological excitement in the hereditary neuropathy world and review the challenges in how we measure disease progression in Charcot-Marie-Tooth disease. Then I'll take you through 2 natural history studies that we've done in 2 common forms of CMT, so notably CMT1A and CMT1B. And we'll talk about some of the difficulties in those natural history studies and the measures that we're using currently, and then move into some of the emerging outcome measures and biomarkers in Charcot-Marie-Tooth and the great need for those to continue to develop. And then I'll shift gears and we'll talk about the implications of genetic neuropathies for more common disorders. And we'll look at it through the lens that Brian mentioned of this rare disease, hereditary sensory autonomic neuropathy type 1, and the deoxysphingolipid hypothesis in that condition that I'm evaluating in diabetic neuropathy to see if we can deem some insight from rare to common. So I heard there were a lot of medical students and residents today, so we're just going to go through a case for those of you who haven't seen a lot of genetic neuropathies in your clinics yet. So this is an 18-year-old woman who I think really will represent to you the common manifestations of this disease. So what she tells you in clinic is that in the first decade she walked on time, but she was clumsy with running and she was invariably last in races at school. And this is a question I learned to ask during my training at Queen Square. It's really very powerful to ask, did you run like other kids? She had high arched feet her whole life, but it didn't get in her way. But then by the second decade, she's turning on her ankles more. She's had a few sprains, trips to the ER, and she's getting more back, hip, and knee pain than her peers. And also she's noticed some difficulty with writing. So her hands tend to cramp during exams, making it difficult to finish on time. So when you go to examine her, she's slightly unsteady. She's got a steppage gait when she walks, can't stand on her heels. And she has wasting of her intrinsic hand musculature and also from the mid-thigh down. She does have pes cavus, like I showed you in the photo, tight Achilles tendons, and a little bit of scoliosis. And then on her motor examination, there's mild weakness with finger abduction and thumb abduction, and more notable weakness with foot dorsiflexion and eversion. And this is a pretty common pattern you'll see in some of these conditions where inversion can be spared, in contrast to some muscle diseases and other things that might cause foot drop. So she's areflexic, her plantar responses are flexor, and she has length-dependent sensory loss to all the modalities that you test. So that's her exam. So in our clinic, family history is huge, and there's a lot of detailed family history that gets taken. So I'm showing you her family tree. She's the one with the arrow down below. And what you notice in this family tree is there's more than one generation affected. There's multiple family members. So that starts you thinking about autosomal dominant or X-linked inheritance, except that we also see that there's paternal transmission. So male to male transmission would exclude X-linked. So we think this is likely an autosomal dominant progressive neuropathy that she has. And we do her electrophysiology, and we won't belabor this too much today, but she has no sensory responses in the upper or lower extremity. And then on her motor responses in the arm, which are still present, the CMAP, I want to call your attention to this part of the graph. So the motor amplitudes are reduced, and then she has significant slowing of conduction velocity. So in the arm, these should be 50, and you see they're very slow. And I showed you her right arm, but the left was the same. And so what's really important here is that there is confluent uniform slowing. So it's not patchy, there's no conduction block. It's really just every nerve looks very similar. And that again points us away from some of our acquired causes of demyelination and neuropathy and towards a genetic disease. So we'll come back to her, but just to take a step back and say hereditary neuropathies are really diverse phenotypically. So we have the most common presentation, which is hereditary motor and sensory neuropathy, but there's also these phenotypic extremes where it can present as predominantly sensory or motor loss. And then there's hereditary neuropathy with liability to pressure palsies, which sort of stands alone in that there's these recurrent compressive neuropathies, and we won't be talking much about that today. So the two in yellow is where we're going to focus our attention. Together, these conditions are really the most common inherited neurologic disorders, and there's over 120 causative genes that we've already identified, and more, of course, are being discovered all the time. So in addition to the clinical manifestations of sensory motor or both, when we classify Charcot-Marie-Tooth, we think about inheritance patterns. So that's why I showed you her family tree. And then axonal versus demyelinating. So where's the primary insult? Is it at the level of the axon or the myelin? And this was first sort of put together by P.K. Thomas and Anita Harding, and they really made it pretty simple, and they avoided the lower extremity because often those responses are gone. So conduction velocities in the upper extremity or nerve biopsy in some cases is how we define myelin versus axon injury. So most patients, and this gets difficult because there's so many genes, and yet most patients present with the picture that I described to you in that case. So distal weakness and atrophy, length-dependent sensory loss, and foot deformities such as pes cavus, but not only pes cavus. It can really be a variety of foot deformity and other musculoskeletal manifestations. And I always tell my trainees in clinic, because they have pes cavus, they don't necessarily have CMT, and because they don't have pes cavus, it doesn't exclude the possibility. Reflexes generally are absent or decreased, but there are exceptions to that, and the progression is really quite slow. And in severe cases, you can see cranial nerve involvement and respiratory dysfunction as well. So taking a step back, we're at a really exciting place with hereditary neuropathy right now. So for the first time, there really is the promise of disease-modifying therapy for these patients. And it's sort of palpable. This biologic excitement has peaked, especially with the advent of antisense oligonucleotide therapy, RNA interfering therapy, and the success that we're seeing now in other conditions such as TTR amyloid and spinal muscular atrophy. But I really want to emphasize that in addition to some of these genetic therapies, there has been a lot of biology underscored in recent years that has actually paved the way to target these individual pathways that are implicated in the various forms of CMT. And you see that on this slide. And so as we're thinking about this, we're at a time when clinical trials are becoming feasible for these agents. And it is especially important that we have ways to measure both the natural history of these disorders and the response to treatment in clinical trials in a way that's actually and will give us the answer of whether these agents work or they don't. So what are some of the challenges that we're facing? Well, I mentioned these are rare diseases. So some of the disorders we're talking about are present in maybe 100 people in the world currently, or at least those are the patients that have been identified. They're very slowly progressive. So patients in clinic might say, well, last year, I think maybe I wasn't twisting my ankles quite as much. And maybe I was. It's very hard for them to detect progression at certain parts of the disease, and it's hard for clinicians at the bedside. The other thing is that these conditions are very, very biologically heterogeneous. I'm sure you've seen cartoons like this before, just indicating where the various genes act in the cell. And the short story is they can act anywhere, whether it's, any part of the myelin or axon. Biology can be implicated, and you want disease modification treatments that target those specific pathways. Even more confusingly, mutations in the same gene can cause variable clinical phenotypes even within families. And so really, when we think about treatments, we have to almost be thinking on an allele-specific basis for how we're going to treat individual people. So are we prepared for clinical trials in CMT? And this is a nice review from Alex Rosser and Mary Riley in London. And what we really have to be thinking about is if we're going to treat these conditions, we're not reversing nerve injury. Nerves don't regenerate easily. We're trying to slow progression. And so to be prepared, we have to understand what the progression is. So to kind of take a big picture view, what makes a good clinical outcome measure? Well, it has to be sensitive to change. It also has to be reproducible with little variation from one measurement to the next. And then this bottom one, I think, is especially important for us to be thinking about, which is it has to be clinically relevant. So when we're looking at biomarkers as they're emerging now that are very sensitive to change over time, we have to ask ourselves, does that change in the biomarker really reflect what's happening to the patient and to their disease? And we'll talk more about that. So coming back to our patient, so she has CMT1A. So that's the most common form of CMT related to duplications in PMP22. 50 to 60% of all genetically confirmed CMT will be CMT1A, and the majority of demyelinating CMT as well. And patients generally present with that classic phenotype that I described to you and uniform conduction velocity slowing in the demyelinating range. Most of them will remain ambulatory, but a fraction won't. And there are other musculoskeletal and ambulation difficulties, even in those that do remain ambulatory. And again, we're talking about a single gene that's duplicated in all of these patients, but we see this really marked phenotypic heterogeneity in individuals within and between families. And we think that's in part due to genetic modifiers and environmental factors. So the first and sort of mainstay instrument that we've been using to measure progression was developed in CMT1A. And you see that here, it's the CMT neuropathy score. There's been several renditions of the score. The first 3 items measure patient-reported symptoms. The next 4 talk about the examination at the bedside, and the last 2 are electrophysiologic measures. And so this instrument that people really thought about for a long time was put to the test initially in vitamin C trials. And to take a step back on vitamin C, this was a very appealing treatment for CMT1A in that its safety profile is excellent. You're not going to treat CMT1A, which is an insidious, slowly progressive disease, with a very aggressive and toxic therapy. But vitamin C is safe. It also is an antioxidant with promyelinating effects. And we saw in preclinical trials that it reduces expression of PMP22. And also ameliorates the phenotype in the animal model. So it was very compelling, followed by 6 clinical trials, all of which did not show any improvement in people with CMT1A. But furthermore, what was concerning, as you see here, is that the instrument actually didn't show change over time. In fact, there was a placebo effect in the placebo group. So we saw, if anything, stability to improvement. So this was a failure of this outcome measure to tell us whether vitamin C was effective. This led to several initiatives. So one was to develop additional measures. The other was to take the score and perform a psychometric rash analysis on it. So what that means is we were looking to separate patients with mild, moderate, and severe disease from each other by weighing each item on the score differentially based on the psychometric data. And so that led to the development of the CMT-NS rash modified score. So the reason I'm putting this slide here is to introduce the longitudinal study I'm going to describe, but also just to underscore how difficult it is to conduct these studies. So this was done through the Inherited Neuropathies Consortium led by Mike Shai in Iowa. And you see the number of people around the world who had to collect this data uniformly using this instrument. This requires trainings and retrainings, and it's a huge effort. So we took this rich data set and we asked the question of, do CMT examination scores that are rash modified show change? And the reason we focused on the examination and not the total score, and I should say the examination score is a subset, so just the patient symptoms, the exam, no electrophysiology. We did that because patients don't always want to have conduction studies, and the multiple sites involved didn't always have availability to do them. So we focused on a subscore, rash modified, and what we saw is that there was change over time that was highly significant, and that this rash analysis based score did show better responsiveness compared to the original. So we looked at the mean change over the standard deviation of the change, sort of the signal to noise ratio, and found that it was highly improved in the rash modified score. But what I want to call you attention to is that the actual degree of change on the score is really quite small. We then looked at whether baseline neuropathy severity will impact the change over time, since that's important for who you recruit for a clinical trial. And we did find that the patients with mildly sort of mild range scores at baseline were the ones that we were seeing the most change in. So both numerically and as far as responsiveness and signal to noise ratio. So we concluded here that the CMT examination rash modified score demonstrates change over time in these patients, and it is more sensitive than the raw scores prior to these revisions, that the scores are most sensitive in people with mild baseline disease severity, and that while highly significant, the degree of change is so small, we would still be looking at hundreds of patients in each arm of a clinical trial, which really isn't feasible. And finally, sort of the gestalt is we need to be using these instruments in conjunction with other outcome measures and biomarkers. So I'm going to shift gears here to myelin protein 0 neuropathy and show you a very similar study, except that this is a much more complex disorder phenotypically. So again, it's 5% of all hereditary nerve and 10% of demyelinating CMT. So these patients are not infrequent. And the phenotypes that have been described are threefold. There's an infantile onset with very severe neuropathy early on, delayed milestones, and very slow conduction velocities. There's a classic presentation, which is very similar to CMT1A. So people presenting in the second decade and having a more gradual progression. And then there's an adult onset, which happens, not only does it happen in adulthood, but it's also hallmarked by normal or intermediate range conduction velocity slowing. So very different, right, between these three groups. The adult onset can also have these unique phenotypic features such as tonic pupils, tremor, dysphagia, and neuropathic pain. So how are you going to design a clinical trial for this disease to address one of those compounds that, you know, is appealing and promising as a treatment? So we again took the CMT examination rash modified score in this population, and we found again that it changes over time, and that didn't interact with age or sex. And then in this cohort, though, it seemed that the rash modification actually reduced the responsiveness as compared to the original score. And this was interesting because it was the same finding that the London group identified in CMT2A. And CMT2A and myelin protein 0 neuropathy are both a little bit more rapid in progression, more aggressive than our CMT1A cohort, which was the basis for the rash analysis in the first place. So that really tells us we can't generalize these refinements to the instrument based on one population and carry to another. The other really interesting thing that was born out of the study is when we asked, well, who's driving this change in our patients? It was those with axonal neuropathy. And you see here that those with axonal neuropathy show change and a good responsiveness. Those with demyelinating neuropathy don't really change. And what is happening here is that the patients with axonal neuropathy are older, and they also report symptoms at a later age. And of course, this was a study predominantly performed in adults. So I think we're just capturing them at a time when their disease is changing more rapidly. And that really is very important when we consider clinical trials and enrollment. We also looked again at baseline severity, and in contrast to CMT1A, we found that it was the moderately progressive patients, or sorry, the moderately severe patients at baseline who had the most progression on the score. This next slide, I think, might actually be the most important in this talk. And so this was looking at the change in the scores by patient. So you're seeing a spaghetti plot for individual patients who harbor the mutations listed at the bottom. And what I want you to take away from this is it's really erratic. So these people are getting better, they're getting worse, they're changing at different slopes. So there's really profound heterogeneity here. And not only in the intergene difference, but also in patients with the same allelic change in the gene can show very different progression. And this makes sense, right? Because we're capturing people at different ages. We know that the onset isn't the same, it's not uniform. So when we're thinking about treatments and trials, we really have to be holding on to this idea of sort of personalized approaches to measuring change. We concluded from this study that the CMT examination and RASH modified examination score shows change, that those scores are really particularly sensitive for axonal and moderately severe MPZ neuropathy, that again, the degree of actual change is quite small, and that there is really this marked heterogeneity in the progression that we have to take into account. So what next then? How do we try to address these limitations? And so there's been a huge push to develop new outcome measures, and particularly new outcome measures for children, because of course that's when you would ideally want to treat a genetic nerve disease. And so we have the CMT pediatric score that was spearheaded by Joshua Burns in Australia, that's done very well in multiple forms of CMT as far as showing progression. There's a CMT infant score now as well. There's a functional outcome measure that focuses less on bedside examination and more on what the patient's actually able to do. Myometry has shown promise, and then a CMT health index, which is a patient-reported quality of life measure, has also been developed and is being looked at longitudinally. And then the biomarkers. So I think, all of you are gathering from this, we need something more objective than our bedside exam for these patients. And so one thing that's offered a lot of promise is calf muscle fat fraction on MRI. So as nerves degenerate, the musculature becomes replaced by fatty replacement. And we've seen from the London group's work on this, Jasper Morrow and others, that the yearly change in this fatty replacement is really quite impressive. And we could bring our sample sizes down significantly if this was to be our primary outcome measure. But let me bring you back to that initial question of what makes a clinically relevant biomarker. So they've done a nice job correlating these measures to clinical outcomes. But as far as, if your fatty replacement changes X amount in a year, but the patient hasn't experienced any change, how do you really know that it's telling us that the patient is progressing? And so the other issue with MRI is it's expensive, and it also looks at select musculature. And for that reason, there's been a development of plasma biomarkers. Neurofilament light chain has been shown to be elevated in patients with CMT by Alexander Rosser and colleagues. And then also there's a transmembrane protease serine 5, which is a myelin protein biomarker. So whereas the neurofilament reflects axonal injury, this latter one will look at myelin. And that's important because we've talked about the different phenotypes, demyelinating and axonal. So with that, I want to shift to the second part of the talk. We've talked about kind of overall measures of progression that we can apply to different forms of neuropathy potentially. And now we're going to talk about sort of a disease-specific biomarker. And I'll take you through the journey that Brian initially introduced of how I'm hopeful maybe we can shed light on diabetic neuropathy through looking at this pathway. So hereditary sensory and autonomic neuropathy type 1 is an autosomal dominant axonal sensory motor polyneuropathy. So it's really quite a misnomer to call it sensory autonomic because the autonomic involvement is pretty scant, and these patients can have a lot of weakness. Another hallmark of this disease is the dissociated sensory loss that you see early on with a very striking small fiber predominance in these patients. So they lose small fiber function first. And then also they ulcerate and have very frequent osteomyelitis to the point of requiring amputations. This is really devastating for young people, some of them who are losing limbs to this disease. Neuropathic pain, which is also something we don't see a ton of with hereditary nerve disease, is very prominent in this disease. And so I'm just sort of foreshadowing to you some of the overlap that clinically, may relate this to diabetic neuropathy. So taking a step back before we dive into the mechanism, I just want to say a couple words about sphingolipids for those of you who don't think about them much. This is a class of lipids containing a backbone of sphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphingosphing these molecules are essential structural components of the plasma cell membrane and also are very important to signaling. And that's especially true in the nervous system. So the mechanism of HSAN1 has been pretty well delineated. And what's happening here is that there are mutations in serine palmitoyltransferase, which is the enzyme that catalyzes the first and rate limiting step in the de novo synthesis of sphingolipids. So when SPT catalyzes palmitoyl-CoA and serine, the product is sphingonine. However, the issue is that serine palmitoyltransferase, when mutated, has more of a predilection to these alternative substrates, which are alanine and glycine. And that results in the formation of deoxysphingolipids, which are atypical lipids that can't easily be broken down by the canonical process in the cell. And they also can't be converted to downstream sphingolipid molecules. So importantly, these molecules are known to be neurotoxic. So in the DRG, they affect neurite numbers, neurite retraction. And again, just to foreshadow, in addition to neurons, they are also toxic to neuronal origin cells. And that includes beta cells of the pancreas and retinal cells, which of course are very important in diabetes. So in the next few slides, I'll take you through the strategy to target this pathway, and it's been shown to be effective in HSAN1. So what happens is if you flood the enzymatic environment with serine at high doses, you can potentially shift the pathway back towards sphingosine, which is what you want, and away from these atypical deoxysphingolipids. This was looked at in transgenic SBTLC1 mice, so these HSAN1 mouse model by Garofalo and colleagues, and they showed that within days of supplementation, they were able to suppress these abnormal deoxysphingolipids to near normal levels without affecting endogenous sphingolipid molecules. Furthermore, the animals that were treated early on had a notable improvement in their rotarod performance. And I'm not showing you the full data here, but in contrast to L-serine supplementation, if you supplement alanine, you shift the pathway the other way towards these atypical molecules, and the animals actually do worse. So the question we asked when I was still working in Boston is, can L-serine improve neuropathy in humans with HSAN1? And to this end, we conducted a clinical trial in partnership with the Dieter Foundation. So this is a family that's been affected generation after generation by this really difficult illness and really has advocated beautifully for their disease and for understanding the biology. So we took 18 patients, again, very rare disease, so small trial. 9 were randomized to L-serine, 9 to placebo, and following a year, there was crossover of the placebo arm to treatment as well. What we found is that the deoxysphingolipids were suppressed similarly to what was seen in the animal model to very low levels. And that on our CMT neuropathy score, the same score we've talked about earlier in the talk, we saw an improvement with treatment. You see that solid black line, and then a crossover at the red line, the placebo group starts to also improve. So this is very compelling. It's given hope to these patients. They've continued on L-serine, but I want to challenge this a little bit and just ask the question we were asking earlier in the talk. Is this the correct clinically relevant outcome measure for this disease? The CMT neuropathy score was developed in CMT1A. I've already described CMT1A to you. It is not the same as HSAN1, where patients are losing limbs and having severe pain as part of their illness. And so are we measuring the right thing? So let's pivot here and talk about what we can learn from this disease in application to more common neuropathies. So of course, diabetic neuropathy, in contrast to HSAN1, is the most common polyneuropathy worldwide, affecting half of patients with diabetes approximately. And of course, that is becoming much more critical as diabetes rises. It's the leading risk factor for foot ulceration and limb amputation, and the strongest predictor of mortality in type 2 diabetes. It's also the leading cause of hospitalization and expense. And as actually the folks at this institution have delineated, number one, glycemic control is not enough. It's not adequate in type 2 diabetes to control neuropathic progression. We know that. And also glycemic elevation isn't the only issue in these patients. And there's a lot of other metabolic drivers of neuropathy. So again, just to emphasize, there are some phenotypic similarities to HSAN1, which is kind of what drew me to this question in the first place. But then also in recent years, there's been mounting evidence that this deoxysphingolipid elevation is seen in other conditions beyond HSAN1. And some of those are metabolic syndrome and type 2 diabetes. Furthermore, Hamad and colleagues looked at a type 1 diabetes cohort and the control and complications trial of type 1 diabetes, and they found select elevations in deoxysphingolipids as well. And they were comparing patients who had neuropathy by report to those who did not, and those with neuropathy had higher deoxysphingolipids. So paclitaxel-induced neuropathy, very different, a toxic chemotherapy-induced neuropathy, also is associated with these elevations in deoxysphingolipids. And this next one is really interesting. So neuropathy associated with mitochondrial disease. So this is very different than HSAN1, where we have a known genetic enzymatic defect. So in this mitochondrial cohort, they just saw a difference in substrate availability, meaning that serine was lowered in these patients' plasma and that they had a buildup of these molecules for reasons that are not well understood. And then I want to spend an extra minute on this last one because I think it's especially interesting, which is macular telangiectasia type 2. So this is a rare macular condition that results in visual loss. It's hereditary. And Gattner et al. Recently demonstrated that these patients actually have mutations in SBTLC1. So they shared the same gene as our HSAN1 patients. Furthermore, they then looked at visual exams and retinal assessments in the HSAN1 neuropathy patients and found that they had changes consistent with MACTEL. But I think what was even more compelling in the study is those patients who did not have a genetic defect were found to have elevations in deoxysphingolipid also, and they had lower levels of L-serine. And they also show in the study that the serine negatively correlates with deoxysphingolipid, whereas alanine correlates positively. So sort of again suggesting that the substrate availability is important in the accumulation of these molecules, which the authors go on to show in really beautiful work are toxic to retinal cells. And we won't go too far into that, but it was a very exciting study for me thinking about this pathway. So here's a few slides looking at preclinical data in type 1 diabetes animals. So these are streptozotocin rats who were treated with L-serine. And there was a preventative and therapeutic schedule with which they were treated with an L-serine enriched diet. So either immediately or 8 weeks following birth. And so you see here that the serine supplementation, again, reduced the at baseline elevated deoxysphingolipid levels to comparable levels for the non-mutated animals. And that was true with the preventative and therapeutic schedule, and also true independently of weight, glucose, triglycerides, and other metabolic measures. In addition to lowering these molecules, they were able to demonstrate improved mechanical sensitivity, again, both in the preventative and therapeutic schedule. So we won't review all this data, but I can summarize it for you and tell you that serine supplementation did lower deoxysphingolipids in STZ rats and also improved nerve function on multiple assays, so mechanical sensitivity, sensory nerve conduction velocity, and a shift towards larger diameter axons in sciatic nerve. And since the study was published, I was involved with a study that was similar in the DBDB mouse with Florian Eichler, and again, those results looked similar as well. So we know that rodents are not people. I really like this paper from Mary Riley's group as well. And so the question I wanted to ask was, can we look in the plasma of humans who have diabetic neuropathy and try to understand if this pathway is similarly applicable in distinguishing our patients with neuropathy? And I got very fortunate here to collaborate with Brian Callahan and with Ava Feldman here. And they had a really wonderfully characterized cohort that Brian had been working with as part of the bariatric studies. And we looked at 4 groups that you see here: lean, obese, obese with type 2 diabetes, and obese with type 2 diabetes and neuropathy. And they were fairly well balanced groups. And so to take a quick step back, what I wanted to really look at here was not just are deoxysphingolipids elevated overall, but are there specific subspecies that we might be able to hone in on to have a more pathway specific approach. And what we find is that these molecules here in red, deoxydihydroceramides, are the ones that are represented when you look closely at the different speciation of these molecules. And we were able to do this with collaborators in the lipidomic lab at the University of Colorado who were able to kind of detail this for us. And what's interesting is this is the same molecule that was honed in on in the mitochondrial disease patients I talked about earlier and in the macular telangiectasia cohort. So there's sort of a mounting sense that these are the bad players that are potentially causing the neurotoxicity. So what we found is that indeed the deoxysphingolipid concentrations were elevated in people with type 2 diabetes, obesity, and neuropathy as compared to controls. And that was true for these dihydroceramide species almost across the board, as well as the total levels. We then examined the serine alanine ratios, and we saw that serine was lower in our neuropathy group and alanine higher as compared to control. So kind of supporting this potential hypothesis that altered amino acid profiles could be contributing to the accumulation of these deoxysphingolipid molecules. And similarly to what was seen in MacTel, our serine negatively correlated and alanine positively correlated with the deoxydihydroceramide levels. Because this was such a well-characterized, detailed cohort in regards to neuropathy, we were able to then take deoxysphingolipid levels and alanine to serine ratios and correlate them with neuropathy-specific outcomes. And you see that there's modest correlations. I don't want to overemphasize them, but they are in the right direction of deoxysphingolipids correlating to the MNSI questionnaire and negative correlations with sural amplitude and nerve fiber density in the leg. And what was really interesting in this cohort is that when we focused on the obesity-only patients, so those who had no evidence of diabetes yet, we saw that some fraction of them already had abnormal nerve fiber density, which of course echoes everything Brian Callahan has been studying and makes sense. But when we took the normal versus abnormal nerve fiber density patients and compared them, the abnormal nerve fiber density people with abnormal nerve fiber density already had elevated deoxydihydroceramide levels. So that was also quite interesting. and really implicates that this is a metabolic neuropathy that we're examining more so than a glycemic one. So conclusions here were that deoxydihydroceramide species are higher in individuals with obesity, type 2 diabetes, and diabetic neuropathy as compared to lean controls, that alanine to serine ratios positively correlate with these molecules, and that both the ratios and the molecules show a positive correlation with increased DN severity. So maybe there's a signal there for a causal contribution of the DSL pathway to diabetic neuropathy, although of course it's very early to say that. So looking forward, it seems at least that this is a pathway that may be worth paying attention to, and that further study of this is warranted. And so where to go from here? So recently, we had really a great opportunity to partner with the Today study. So this is the treatment options in type 2 diabetes in youth and adolescents study headed by Philip Zeitler. And they have studied these kids who are now not kids, but young adults over many years. So starting in 2004, our study that we're going to be looking at will start in 2008. And here's this slide from a recent publication that's really quite upsetting, actually, if you look at it. So these are young people with type 2 diabetes, and you see that they are accumulating the really frightening complications of type 2 diabetes at a really dramatic rate. And that includes nerve disease. So they start with a baseline prevalence of 1%, but their cumulative incidence is 32.4 after 15 years. And so this is a real metabolic sort of phenotypic extreme, and it's really important to try to understand what's happening here, and also an opportunity to look at some of these potential biomarkers over time. And so the study that we are in the process of now is looking at a subset of patients from this cohort. So these are young people with type 2 diabetes with and without diabetic neuropathy, defined by the Michigan Neuropathy Screening Instrument Examination Score. And again, they're pretty well balanced groups, aside from those with neuropathy had a higher hemoglobin A1C, which is not terribly surprising. And we'll be looking at longitudinal plasma samples from this population and kind of digging into what we can identify as far as other metabolic risks as well. So I'll conclude here, and I hope I've convinced you that measuring progression in Charcot-Marie-Tooth disease or hereditary nerve disease is very challenging, given the slow disease course and this marked biologic and phenotypic heterogeneity. I also have shown you that our currently available clinical outcome assessments, they demonstrate change. They're important to have, but they have important limitations as well. And this really warrants the development of new measures, but they have to be clinically relevant measures and also biomarkers. And we have to bring those new measures back to the bedside and not lose sight of their direct impact on, what we think is happening to these patients clinically and meaningfully. And finally, rare hereditary neuropathies can potentially inform our understanding of more common acquired nerve disorders. And the other way too, I think, thinking about genetic and acquired disease together in nerve is very telling, and it's been very interesting to walk that path in recent years. With that, I really want to thank Jane Roosh. She's my primary mentor for my K23 and just a really remarkably committed mentor and researcher. Stefan Sillow has helped with the statistical analysis for many of the studies I've shown you here today. Brian Bergman and Simona Zarini were instrumental in the deoxysphingolipid analysis in the lipidomic laboratory. Florian Eichler, of course, for the HSA-N1 work at Mass General. And I want to really emphasize Ava, Brian, and Radhika for all of their guidance, their mentorship, their support around these studies. It's really, it's made them what they were. And then the Today study group, Phil Zeitler, for helping us work with this very, very important cohort of youth with that type 2 diabetes, and finally the Inherited Neuropathies Consortium. Thank you, and I'll take questions.
Thank you, Vera. Excellent talk. Really impressed with all the work that you've done on CMT, HSAN, and now diabetic neuropathy. Very cool. So yeah, now it's time for questions. If some people, you can unmute and ask a question, or if you want to throw something.
Vera, hi, it's Eva.
Hi,
Very
Eva.
nice talk. Sorry,
Thank
I was a few minutes late. Excellent. I'll ask the first question. For the Today study, which I think is really exciting, are you going to do any neuropathy measurements above the, the MNSI?
That's a great question.
Because it wasn't really designed as a clinical outcome.
No, not at all.
For clinical trials.
No, understood. It's something we thought about a lot. I've gone back to Phil to talk about that. So one thing I can say outright is you cannot biopsy these children. So we have really looked into that. I mean, that's just off the table. So retrospectively, the answer is we can. They gathered monofilament data, which from looking at it so far, I'm not finding to be very promising. And that's really it. So that is what they've done, and agreed. I think a big caveat in our interpretation of these findings will be how neuropathy was defined. That said, I think looking at what we have as a starting point and then winding back potentially to this cohort and taking what we've learned and phenotyping it is the next step. So a prospective study to really try to take what we see here as signals and then dig into what does it mean with detailed outcomes, for sure. Yeah.
Yeah, okay, very nice.
So Vera, I'll ask the next question, Brian here. It seems like one of our big issues with both diabetic neuropathy and CMT is that the disease itself doesn't change very fast. And so it seems that, one way to get around that is large sample size and long studies, which are difficult. And you mentioned the possibility of more sensitive, at least intermediate outcomes that at least might help us know which ones to do the large, long studies on. So what do you think in either CMT or diabetes? What are the outcomes that you're most excited about going forward?
Yeah, I think the first thing to say is that it's a combination of outcomes. So I think I'm definitely at a point where I don't think we're going to be looking at a single outcome. I think in CMT, MRI has been robustly examined. It's been validated across centers and shown to be, consistent and reliable. And I think it's a very important biomarker. I don't think it necessarily can stand alone for the reasons we've talked about. I think what I would like to see next is sort of a correlation of that biomarker with functional measures and potentially longitudinally trying to look at those two together. So ideally some functional, like the FOM that I mentioned, if we could really sync those together and show that they interface, that would be important. I think the plasma biomarkers and CMT are a little further along than some other conditions. And I think, these most recent ones that I mentioned, both like the NFL and the Schwann cell specific, the problem with those, of course, is that they're elevated early in the disease, especially in these children, and they may not change over time meaningfully. However, if you had a treatment, if there's an ASO that actually makes its well into the Schwann cell and is effective, I think that, you're going to be looking for a reduction in those levels, regardless of whether it would be changing significantly year to year. You're looking for some sort of improvement. And someone asked me at a recent talk, so are we ready for clinical trials for an ASO and CMT? And the truth is, I think it depends on how well it works, right? If it's a really dramatic effect, I don't think you need 10 very detailed outcome measures to prove that it's doing something. At least I'm not seeing a lot of TTR patients on treatment, but my impression is that these are not extremely subtle effects when they're effective. And so in that setting, I think what we have is probably a good start, right? Whereas if we're looking at something that marginally slows progression, well then yeah, we're not ready.
Well, that's a great point. Interestingly, amyloid neuropathy is also relatively slowly progressive, and when we have a therapy that actually stops it or actually improves it rather than just slows down the progression, it's much easier to see the effect. So yeah, I think you're onto something there, that we need that level of type of intervention to be able to study it well.
And that's the hope, right?
Yeah, that would be good. So we have another question in the chat here from Amro. Amro, do you want to read it, or I can read it if you don't?
Oh, sure. Can you hear me, Vera?
Hi,
okay.
Amro.
Hi, yeah, nice, great hearing your talk, and just had a question. So, I guess podiatry is often not part of the discussion with CMT in terms of outcome measures and foot architecture. I was just curious if that is something that's just too slow or something that could be looked into as a sort of degree of denervation. It's simple, it's inexpensive. And then the other question was actigraphy based, just pure distance walk per day, just thinking of cost-based, cheap, possibly for consideration as outcome measures. Just your thoughts. Thanks again.
Yeah, those are great questions. So first of all, I think foot architecture is important. I think there hasn't been enough focus. students ask why pace cavis happens. And I think the honest answer is we don't know the answer to that, right? And I think that studying it, and I know that you have some focus on this, is really important. I don't know exactly how you would factor it into a clinical outcome, or how, I wouldn't imagine you'd expect it necessarily to respond to therapy in any rapid, meaningful way. But I think understanding it and understanding its own progression separate from nerve is really helpful. And we should be partnering more with our podiatry colleagues around that, and our orthopedic colleagues. And one thing I was really glad to see is that the London group did do an orthopedic study, at least looking at how orthopedists approach these deformities, how they choose to operate on them, because as we know as clinicians, it's all over the map. But to your point, I think it's really important, and I think it's understudied, and I hope that you're going to take it forward. The second question, there are a lot more of these easy kind of functional measures being looked at, particularly because of the COVID era, right? So if you imagine that this longitudinal data collection had to halt, and all of those patients missed their in-person visits. And so there is a virtual outcome that's developed through the Inherited Neuropathies Consortium. I don't remember if they've included like an octography sort of as part of it. I think you have to be a little bit careful with just people's varied levels of activity when you're thinking about that, and how meaningful it will be in a subset of patients who don't move around a lot, which with CMT, kind of like in diabetes, exercise, there are challenges to exercise and to moving around. But yes, so there are these new kind of patient, more driven measures that people will be looking at. Absolutely.
Thank you.
Thanks, Amro. Any other questions? Feel free to put it in the chat or unmute. All right, looks like Kellen's asking a question. Kellen, do you want to unmute and ask, or do you want me to do it?
Sure, I'll unmute. If my dog barks, I'll mute again. So we tried to look at the FSHD clinical scale as similar to the CMT sort of questionnaires, this ordinal scale that really had a lot of shortcomings when looking at outcome measures for this genetic disease that hopefully would have sort of targeted therapeutics in the future. But even in a sort of multi-centered natural history study, we only had like 47 patients with sort of comprehensive outcome measurements where we felt like we could use that to factor load into a rash model. And so we couldn't transition the FSHD clinical scale into a rash score. So we sort of aborted it. But so do you think for these more rare diseases that have the opportunity for targeted therapeutics, do we make new scales, or is it going to be based on, pathology, biomarker changes, patient reported, things like that? How do you go about this?
So I think you need both. And I don't think you can get away from a clinical assessment. I really don't. And I think that as far as rare disease is concerned, there is tremendous power in consortia in trying to do what you're talking about. I mean, I didn't show you the sort of table one for each of these studies, but the CMT1A study had like 1,400 patients in it. I mean, that is a tremendous effort if you think about what that means to recruit. We had tons of missing data. We had patients who, came at baseline and never came back. Absolutely. But that is tremendous, right? To see that signal and then to perform some of these rash modifications. I worked with Reza Sajjadi on that. He's helped sort of design the rash, and you need the sample sizes. And in FSHD, I mean, it's rare, but again, with multi-center studies, and I can't push hard enough, I think, for collaboration around this. I think when everyone's doing their own scale development, their own natural history study within one or two institutions, it's sort of taking those patients' time and effort, but it's not necessarily answering the question, right? So the more that we can congeal our efforts around this and bring patients together, and they want that, patients want that, right? These advocacy groups they're international now. I mean, they're really connecting. I think we have to respect how important that is. And I learned that lesson from the HSA-1 study, because that population wasn't the only HSA-1 population in the world, and yet they were the ones participating in that effort. And there will be another study out of the UK, and I'm hoping it's going to, refine some of what we looked at. So anyway, my short answer is I think you have to collaborate widely to get this done.
Thanks.
Great question. Any other questions for Vera? We have a couple more minutes, otherwise we can end a teeny bit early.
I have a quick question, Brian.
Thank
So,
you, Peter.
so very nice talk, Vera. You know, as a person who's taking care of rare diseases as well, I think we're often faced with this difficulty where we have at best incomplete data about what we can use in a given patient. So, I mean, I assume now with the L-serine study that you probably are using this, or most of the patients are probably using L-serine in you know, all the HSN1 patients you're seeing, given that it's safe and it's cheap and publicly available. But obviously, if it was not all of those things, then it gets much more complex. And so I'm kind of wondering how you're thinking about this going forward. So, you know, there's also the fact that L-serine's safe, cheap, and not really going to be patentable. So there's not going to be a drug company that's going to want to run a multi-million-dollar trial in diabetic patients. So how have you kind of bridged these complexities within this broad space of wanting to make a difference in a rare disease, wanting to have that translate to bigger pieces, but there's a contextual piece to the way we approach these things that I think is often lost in the details. And I just want to give you a moment to speak about that a little bit more.
That's a great question. And like, as usual, Peter, very well articulated. I think that the HSA-1 study to me has been kind of an existential burden. I started that study as a fellow, you know, I was still training and trying to understand. And this idea that we have a biomarker that's effectively suppressed through a pathway that's well understood, like it really all hangs together. And yet our outcome measure is not one that is measuring necessarily the predominant clinical features of the disease. And so it responded in a small cohort. And like, what do? Do you put everyone on L-serine? And to your point, L-serine is safe, it's available. But it's a lot of L-serine. I mean, swallowing all that L-serine 3 times a day is not a trivial undertaking for these patients. And also it can have some side effects. They're not major, but some people have, you know, stronger menstrual cramps or a little bit of more neuropathic pain. And, you know, patients might take that as a sign that things are getting better, regenerating. Do we know that? I don't know if we know that. I think one thing that probably should happen, and I'm not sure is happening in detail, is we should follow these patients on their L-serine and continue to see how they do compared to placebo. I think Mary Riley's group, when they do their trial, will use MRI, and they have looked at MRI in conjunction with HSN1 and shown that it's sensitive in their population. So I think a more careful natural history study preempting the clinical trial is probably what you really need in this disease. So right now, do I tell all my patients to start L-serine? I don't. I tell them this is the data we have. I spell it out. You know, this is what we saw. This is what we know. This is what we don't know. And this is what the burden is of taking this medication. Most of the participants of the study have stayed on it. They've chosen to stay on it. But I'll tell you that some of the new people with HSN have chosen to wait for more data. So I think it becomes a personal choice. Now, your second part of that question with diabetic neuropathy, I don't think that I'm doing this work with the sort of thought in mind of we're going to find serine to be the ultimate treatment for diabetic neuropathy and put everyone on it. I think my framing of it more is what can we learn about these pathways and what can we understand biologically. Ideally for HSN1, I want to see a genetic therapy. It feels like there should be one eventually, right? And it should work more definitively than something like serine supplementation. And it's messy to give people high doses of serine, and you know. So I think we're looking for things ultimately that are more pathway specific, more targeted than just flooding this environment with serine. But I think learning about it is very informative to pave the way for that, if that makes sense.
Awesome. Great questions, great answers. Anything else before we wrap up? We're almost out of time. Perfect. Well, with that, Vera, I'll thank you for an excellent talk and excellent answers. I'm glad you left time for lots of good questions from the audience, and can't wait to see you again, hopefully in person next time.
Thank you all so much. It was really a pleasure. Thank you.
Bye, everyone.